Thank you very much, Pierluigi, for the invitation. And I must say also that I have to congratulate you for really this excellent webinar, highlighting different aspects of the treatment of cancer. So my task is to look critically at the extension of the criteria of HCC for liver transplantation. As you know, today it's a little bit a hype. Many people think there are no limits anymore for inclusion, but I think we should really have a critical eye on this. So we know all from the beginning, from more than 25 years ago, that the selection for liver transplantation is based on the restrictive Milan criteria with excellent results. And I want to underline the importance of recurrence-free survival. This is for me the most important endpoint and not overall survival. And this restriction was picked up rather rapidly 5 years later by the San Francisco group. And in fact, what they did, they only extended the tumor burden by 1.5 centimeter. And the result was that you can transplant, in fact, more patients than keeping just in mind the Milan criteria. So what is a little bit particular is that based on 119 patients, 25 years later, we still discuss about inclusion criteria. I find this really remarkable that this could happen. And we find this back also in the classical, of course, I will call it BCLC scheme. I am not a favorite of this scheme, not at all, because I think it is a scheme that denied really the access for many, many patients, not only to a treatment, but to a curative liver resection or a curative liver transplantation. So you see the place of transplantation is in fact very limited. And if we translate this in this iceberg slide, you see that in fact the Milan and the UCSF criteria allow only to transplant a small number of patients. But we now know that when combining morphology and biology, we can extend this criteria rather safely and we can have good results. And this slide about extended criteria shows very well what is at our disposal today. What is in blue on this slide corresponds to the Milan UCSF criteria. And this is in fact what we have today and what we should also use rightly to allow to give the highest number of patients and access, not only to a treatment, but to a curative treatment. And in this context, I want to remind to everyone, because it's forgotten, that Starzl designed liver transplantation, in fact, not to cure benign liver disease, but in begin to cure hepatobiliary, hepatocellular cancer, and even secondary liver cancers. And we know that this is today the hot topic of almost all meetings. So we have now a possibility to do something before the transplantation, which allow us to control the factor tumor in many patients, but we have also at our disposal, and this is really underused in the Western world, living donor liver transplantation, which in fact allows you to control the factor time. And this is of course very important if you approach HCC not anymore from a surgical or a medical or a transplantation standpoint, but from a real oncologic standpoint in which you can apply neoadjuvant and adjuvant treatment to these patients. And the extension of this criteria has been very well shown by the Kyoto group. And you see in this slide that they extended the indication to up to 10 tumors on the condition that the biological marker, which is DCP, is beneath a certain level. And DCP is in fact a good surrogate for microvascular invasion. Of course, we know that there is no perfect marker, but I cannot understand neither why DCP is not used more in the Western world in relation to HCC surgery, medical treatment, and transplantation. The extended criteria, we should not only look to a static marker, but also to the dynamic tumor behavior. Just this slide, this was published by our collaborative group in Europe already many, many years ago and showed that the Milan criteria outpatient, if they had a response to local regional treatment using mRECIST and if the AFP slope progression was lower than 15, that the outcome was exactly the same as Milan in criteria. And at the right side, you see the findings again from UNOS, which shows that if you do a downstaging and you have a response, you have a significantly better survival. Now, I am already intrigued by this situation since many, many years, and I decided 1 or 2 years ago to go in the literature, and I found not less than 56 scores in the literature in relation to inclusion for liver transplantation. And since I made this slide, there are already two new more scores published. So this means, in fact, that nobody is very happy with the selection criteria as we use today, although most allocation organisms allow us to follow these guidelines to put patients on the waiting list. And you see from this slide, when compared to Milan criteria, that we indeed can transplant much more patients based either on extension of morphologic criteria, of morphologic and biologic criteria, and even on the basis of radiology and pathology criteria. What was interesting, what we did in this study, which was recently published in an Italian journal, was that if you look at the overall survival for all these extension criteria, that in fact you reach an almost 75% overall survival, whatever is your criteria. But even more interesting, if you look at the recurrence-free survival and you stay within the widened criteria, that the results remain excellent. And if you go outside these widened criteria, the results come very bad. So, of course, if we select patients for transplantation, we must respect some ethical principles of justice, equity, and especially of utility of a scarce organ source. So extended criteria, I think, yes. If you can combine biology with morphology, you see that we can already transplant much more patients. The question comes up now, if we can go further and go to the so-called advanced stage C. It is clear, the more you extend the criteria, the more you become in a gray area of uncertain results, and the higher, of course, is the risk of recurrence. Now, the first groups, and this is not surprisingly, which looked at these extension of criteria were the SEO groups in Korea. I think these are really the leaders in the field now of transplantation in the world. And what they did is they combined, as you can see, PIFCA and AFP. That's already a good thing to do. But what they showed, and this is a very important study in my opinion, because about 1/3 of the patients they included had a portal vein tumor thrombus. And all these patients had local regional therapy. And you see if the score is low, if this moral score, moral means the model of recurrence after living donor liver transplantation, that the Milan criteria in fact do not play a role. So this is the first study which a larger amount of patients transplanted with a portal vein tumor thrombus. And if you go down in the literature, you see that we are now evolving from extended to advanced criteria, and you see that the main progresses and the main information in this field come from living donor transplantation. This is logic because you don't have to take care of your organ scarcity. It comes mostly from the Asian world and especially from Korea, as you can see. There is only one study published recently in relation to a compilation, I would say, of cases transplanted in different centers, having 1 or 2 patients which have been successfully treated. But I am not so in favor of this kind of studies because it will not allow us to go forward. So we are speaking now about advanced criteria. And if you look at advanced criteria, in fact, we go back in history and we join again one of the conclusions of the consensus conference of the NIH in 1983. This is 40 years ago, where they said that primary hepatic malignancy confined to the liver but not amenable to resection may be an indication for transplantation. Results to date indicate a strong likelihood of recurrence, but importantly, the procedure may achieve significant palliation. So we come a little bit in a sort of philosophy. If we go to advanced criteria, should we aim for a potentially curative treatment, or should we aim for a potential palliative treatment, as is in fact done in many fields of oncology and surgery? So there is a recent interest, as you have seen from these publications, to extend the indications to advanced criteria. It means macrovascular invasion. This is mainly an Asian experience and LDLT experience. But if we want to justify this, we must look to past experiences in both liver resection and transplantation. And of course, we must also keep in mind the ethics of transplantation, one of the best fields in medicine to look at ethics when you do a therapy. And the futility is, of course, very important in this context, especially in the Western world, while you depend mostly or merely on diseased donor liver transplantation. So what do we know from the past in relation to liver resection? In fact, nothing new. These are publications from more than 20 years ago, as you see already, huge Japanese experience with an important number of patients resected for HCC with a portal vein tumor thrombus. And you see that the results are in fact not so bad, 40% survival at 5 or 6 years in patients who had also a pre-surgical treatment. And this has been confirmed in a much larger study 15 years later. This was done a Japanese multi-center study, and they find immediately out that VP4, this means a tumor thrombus in the portal trunk, is not a good idea to resect, and you will see later on also not to transplant. And as we heard before, serum alpha-fetoprotein rise is of course an important marker. What about the past experience in liver transplantation? Many of you are sitting here know that I like to look back in the transplantation history. Again, a study published more than 20 years ago by Starzel's group. And you see what is important for me is that this is one of the few studies in which the follow-up is at least 7 or 8 years. Much results are published much too early. You cannot judge anymore in cancer treatment. The results are 3 or 4 or 5 years. As Myron Schwartz just pointed out, after 3 years, whatever treatment you do, the overall survival will almost be the same. But you see that macrovascular invasion is a very bad, of course, prognostic factor, and you have almost no survivals. And these were usually patients with portal vein tumor thrombus number 4, so it means invasion of the portal trunk. And this has been confirmed, this earlier experience in a more recent ELTR study, in which you see on the slide that macrovascular invasion always overrules any other classification. Now, recently, there has been a lot of interest to this in the Assam Medical Center and Seoul National University centers. And this is the first publication, and this shows, in fact, I think, if we want to go to these advanced criteria, that we must be logical and that we must apply really offer a complete modality therapeutic scheme to the patients. You see all these patients had TACE before the transplantation, they had stereotactic beam radiotherapy followed again by TACE, they respected an interval and then they transplanted a patient. Patients with portal trunk invasion were excluded, and you see if you look at the outcome, but it's only 15 patients, but you will see situation rapidly changes. It's a publication, preliminary one of 2017, that you can have good survival. If you compare pre-transplant radiology with explant pathology, you have a little bit a better refinement of your results. And the disease-free survival, what is important, is 80% in these small series, and the patients are at least within Milan criteria. So Milan criteria surely keep their value in the context of extending indications for transplantation. I went then through the literature to do another review, and as you can see, I took here the most important series, more than 10 patients published during the very recent years. You see already that there has been only one prospective study done. You see also that the two centers who do best, in my opinion, is the Medanta in Delhi and Assam Medical Center in Seoul, in which they combine a downstaging using TACE and external beam radiotherapy, followed by TACE or by tyrosine kinase inhibitors before going to transplantation. You see that your overall survival at 3 years, because many results are stopped at 3 years, and these reports can be about 60%. And if you look at the recurrence-free survival, it's going down already to about 40–45%. So from these studies, you can already distillate some risk factors. As expected, portal trunk invasion is a bad sign. If you have no response to downstaging, is a bad sign. This is logical, as you've seen in the different studies. Now, the situation changes already rapidly. I was recently in Seoul, in Asan Medical Center, and instead of now 15 patients, they added in about 4 years, more than 115 patients again. And you see what they do. They include the patient. They are really very strict to the downstaging used. They do repetitive TACE and stereotactic beam radiotherapy. Otherwise, you cannot be transplanted. You have to respect a certain delay between downstaging, not between the initial diagnosis and transplantation, but between downstaging and liver transplantation. And then they developed a SNAP score to judge the results. SNAPs means size and number of the tumor, alpha-fetoprotein, and PIVCA2 or DCP. And they now went even further and now start to include also patients with a portal truncal invasion. The operative strategy is also important, as you can see. The liver is really devascularized completely initially before doing something else in order to avoid mobilization of the tumor thrombus. And you see they resect the portal vein till the confluence with the splenomesenteric joining and do systematically an interposition graft in this position. So you see the progress is in fact very rapidly, so that I think now there can indeed be a place for transplantation in selected patients who have had a very, very strict pre-transplant protocol. And it is to be expected, Ivan Schwartz has a huge experience already in relation to immunotherapy, and this should probably in the future, in my opinion, be added to this, because the dogma that if you do immunotherapy, you have much more rejection after transplantation is already denied in several Asian studies in which this combination is already applied. So there is a recent enthusiasm, you can imagine after these publications. They are mostly based on retrospective studies. If you go to the results, it goes about 400 patients. The median term follow-up is only 29 months. Keep this number in mind for one of my later slides. And it is an almost exclusive Asian LD experience, high volume centers which can offer any therapy to these patients. So I think before jumping on all this, we must be critical. I learned always from Kocher, the first surgeon Nobel Prize winner, that a good surgeon is one who can operate, but an excellent surgeon is one who decides not to operate a patient. So we must interpret the results with care and within context. And the 5 lessons to learn before we can judge this definitively is we must be sure of the diagnosis. We must look at the impact of LDLT. We must look at the impact of local regional pre-transplant treatment. We must also look, when we speak in terms of overall survival, what is the importance of the treatment of recurrent HCC, which is already progressed, and then which is the importance of long-term follow-up. This means we have to look at utility and intention to treat transplant benefit. The first diagnosis. You see, this is one of the patients of mine. He was refused for transplantation because he had a massive portal vein tumor thrombus with the downstaging, and afterwards we did a transhepatic cytology of the place where the thrombus should have been, but the thrombus biopsy was negative. So we must be sure, if we transplant such patients, that the pathology confirms absence or presence of the portal vein tumor thrombus, because otherwise the interpretation of the results is biased. And recently the again UCSF group published this paper about the Avena criteria. An HCC and a portal vein thrombus is not equal to an HCC and a portal vein tumor thrombus. And if you look at this publication, this compilation of European patients with 45 patients reported, and when reviewing already clearly only the imaging, 1/3 of the patients had a false diagnosis of portal vein tumor thrombus. So we must be careful, and also we should not forget that if imaging says that the tumor is gone away, it does not mean that this is true. This is the same what we heard before about ablation. I think doing one time an ablation is not enough to destroy all the cells. I am not aware of any oncologic treatment of infusion that is applied once and has eliminated all tumor cells. So we must be sure of the diagnosis. The second thing is, we should not forget when the results are reported, what I showed you before, 60% 3-year survival and 40% disease-free survival, that this is in the context of LDLT. And the Toronto group showed very clearly in the context of cancer that if you do LDLT, an intention to treat analysis, that the results are significantly better than if you do a post-mortem liver transplantation. And I did a lot of work, as many of you know, with one of my former fellows, Quirino Lei, and we published this now in JAMA Surgical, which is the highest impact factor journal in surgery. And we put together more than 2,000 patients, and you see that living donor liver transplantation in the field of HCC has always a benefit of about 20%. So we must be careful when we read that the patient has a 60% survival in LDLT. If you translate it to the Western world, it would already be 40 or even less. And then you come to the question of utility of transplantation, which has been, for instance, in the UK, defined as a result as less % survival after 5 years. The third critical thing that we must take in account is radiotherapy. You have seen that in the good results from Medanta and Assam Medical Center, all the patients had stereotactic beam radiotherapy. We know outside the context of transplantation that the response rate is about 40%. But we must be careful. It is not because the tumor regresses that he has disappeared. It's not because there is no on PET scan avidity for the marker that the tumor is gone. Imaging is different from pathology. And indeed, if you look at the Medanta publication recently in Transplantation Journal about their first experience, you see that radiotherapy can be an effect in the beginning, but after 3 years, this effect is already lost because the results of the patients who did not get the radiotherapy versus those who had no downstaging is the same. So it is important to take this in account. The fourth factor to take in account is, of course, how can we treat today recurrence? These are all recent studies, as you can see. This is from the United States, I think from Los Angeles, from Bushetil's group. This is from the Koreans. This is from the Paris group, the Paul Bruce in Paris. And you see that if you can resect or treat a recurrence, that of course your survival is much prolonged, and you can even have a beneficial effect after repeated resection. So it means that if we have a patient with extended criteria and he recurs, and we can treat him and treat him and treatment, we of course prolong overall survival, but we did not influence what is the real oncologic outcome of these patients. And finally, the long-term effect. Again, with the work with Quirino, we looked at 2,000 patients, and this will be published very soon. When does the recurrences come? I remind you that in all reported series about HCC for portal vein tumor thrombus, the median follow-up was 29 months. Well, look, you see that 30% of the recurrences of HCC after liver transplantation occur after this period. So we must have longer follow-up before we can really say, this is what we can do, or this is what is justified to eventually do. And we should look, of course, at transplant benefit. And this is a very nice work from the Padova group. You look at your time horizon, you should see what brings really the transplantation. And I put here this small graph from the UK NIH system, in which they changed their allocation system for patients to be transplanted. If your transplant benefit is big enough, you have in fact not the right to be transplanted. So it is important. Transplant benefit means also that we must compare the results with other means of treatment. And for instance, we have surely to compare with transplant, with liver surgery, because surgery, anyway, if you can do it, is the best treatment. Here's a very nice publication from Torzilli with all the world experts in liver surgery, Makuchi, and so on, published 8 years ago. And you see that in these patients with Barcelona class C, that you can have 5-year overall survival of 50, disease-free survival of 25. And this is a little bit the same as we can obtain if we do liver transplantation. And this month will be published in the Annals of Surgery, another work from the Italian group, I like really what they do, in which they show that patients with portal vein tumor thrombus, if you resect them, that the results are, of course, enormously different from all the patients who just do not even get the chance to be sent to a center where resection is done. The results are really important. And what was very good in this study, again, which is now in press, is that patients with portal vein trunk invasion were excluded from the analysis. And you see that even if you have a portal vein tumor thrombus, it means the right or the left portal vein, that the results are still markedly different with non-surgical treatments. So advanced criteria, I would say in summary, lessons from the past and from actual experience. If you have no downstaging, if you have rising tumor markers, if you have no adequate preconditioning, if you have no adequate strategy, the answer is no. The lessons from deceased donor, of course, is that we have to compete with non-tumor patients, and then we have to think more in an ethical direction. So the 5 lessons to judge these advanced criteria for transplantation are that correct diagnosis, LDLD effect, local regional pre-treatment with radiotherapy, treatment of recurrent HCC, and long-term follow-up is very important. But to my surprise, nobody speaks in relation to this about immunosuppressive handling. And we know, of course, that the larger the inclusion criteria for LT, the higher is the risk for recurrence, and the more harmful are oncogenic drugs. And the most oncogenic drugs we use in liver recipient or in liver, even in liver resected patients, because they are also immunodepressed after their surgery, is of course the immunosuppression. And this, again, I want to remind the history. If we go back again 40 years, Starzl wrote already that transplantation has, of course, advantages, but there are also disadvantages, and one of them is the recognition of the problem of oncogenesis in transplant patients. So immunosuppression per se is a pro-tumorigenic, is a pro-oncogenic drug. We know that some diseases, some immune deficient patients have much more cancer than other patients. And we know that immunosuppression is very important in relation to combat cancer. How can we do this? We can, of course, avoid reinforcement of immunosuppression load whenever possible. This means that we should not just treat patients for a suspicion of clinical rejection and give more immunosuppressive load. We did a study, curiously was refused to be published in Western journals, in which we compared patients which had a histological proven moderate or severe rejection, but not treated, because this is our policy not to treat all rejections, and those who needed treatment. And you see that the same patients, the risk of recurrence was 18 times more if the rejection was treated. Secondly, use of anti-oncogenic drugs. There has been a hype to prescribe in all these patients now mTOR inhibition-based immunosuppression. But the only prospective study that has been done did not show really any impact on it. And I think that the impact of mTOR inhibition is only if the patient recurs after transplantation. And this has again been clearly shown by the group of Assam Medical Center with a recent publication in hepatology. The third thing is, of course, how to reduce the immunosuppressive load. This is the best way to avoid that you stimulate rejection. There are several studies, very good, done by one of my good friends, Rodriguez Peralvarez, based on a study together with the late Professor Burrows, which shows that if you have high levels of CNI, that you have more recurrences, and that this difference becomes even more important if you have Milan outpatients. So prophylactic immunosuppressive load is important, and therapeutic immunosuppressive load is important to control and to reduce as much as possible in these patients. And of course, the best way to reduce immunosuppressive load is not to use many drugs. This has been my philosophy since 20 years. We have done 700 or 800 patients till the moment that I retired. We have published these results, not only the early results, but also the late results. And I'm always proud to show what Stars wrote about this study. I do not believe that anything so well controlled has ever been completed in the field of HCC. And you see that if you use almost no drugs, or you use more drugs like steroids, there is no difference in outcome. There is in fact no difference in rejection either. And you have, of course, much less side effects. This was also work we did together with the late Andy Burrows. And can you use less immunosuppression? You can surely. We look, for instance, in Brussels at patients which were only followed in the center, in the transplant center, and you see that 1 out of 4 patients did not take anymore every day is immunosuppression. So medicalization is, of course, a problem when you reduce all the time immunosuppression, because you have to follow the patients more and more. So I come to the last slide. It is clear that transplant oncology is in full development. There will surely be indications for HCC and portal vein tumor thrombus on the condition that there is a very good selection process and also a pre-treatment program. If we are in the field now in the world of disease donor liver transplantation, I think it will always remain difficult to justify this not only towards the hepatologists, but also towards the allocation of organisms, because you interfere with the organ pool, of course. If we interpret the results, we should really look at disease-free survival, because this is for me the most important to justify such an important intervention. And we must, of course, look to transplant benefit. If liver transplantation does not allow to make a large difference with the results of the liver resection, of course, we should go for liver resection. And it is obvious that there is a need for prospective predefined protocolized studies, such as done in Assam Medical Center and Medanta protocols. I suppose that there will surely be some questions about this topic.
Thank you so much, Professor Lerut, for your really wonderful lecture and for having mixed the very nice scientific data with ethical issues that are particularly important when we explore the extended and the advanced criteria for liver transplant. So we now move quickly to the other topic.
I think there was a question, Pierre Luigi. I see there is a question from Myron Schwartz or a comment.
Yes, we have a very short time, but if Professor Schwartz would like to explain the question, please.
Okay, just briefly. The reason why microvascular invasion has long been considered a contraindication for transplant is, of course, because it poses a high risk of extrahepatic spread, because you take out the liver, and so that what's in the liver is not really relevant. Our approach has evolved because we had a number of cases where we treated tumors and then did resection or transplant with no viable tumors seen, to treating patients that present with macrovascular invasion up to VP3 with a combination of external radiation to the portal vein, radioembolization to the lobe where the tumor is, and immunotherapy. And if we see complete response radiographically, which is in the majority of cases, rather than proceeding directly to transplant after any predefined period, we follow the patients. And if there's evidence of viable tumor in the liver without evidence of extrahepatic spread, at that point, we consider moving ahead to whether it's resection or transplant, depending on the circumstance, but not going ahead in the absence of evidence of disease after that type of a therapy, which commonly is really quite effective in these cases.
I agree.
Okay. Professor Lerut, would you like to reply to the...
No, yeah, I agree fully. I think if you go to this indication, you must have a project and be able to offer all therapeutic modalities, as Myron explained. But I am a little bit afraid what I heard on meetings. You know, this is again an idea that comes up, and everyone wants to start to do it. And I think we must avoid, and that's the reason why I did also the critical review, because the results must be interpreted differently. I would say if you do diseased liver donor transplantation, and you know already that the results are 20% less good than LDLT, it's difficult to defend in your surrounding that it is a good indication. So I think we must put everything together, as Myron said.